this segment, we're going to talk about geriatric patients. Anybody over the age of 65, sometimes considered over the age of 70. I think it's important to start with just a general overview of some of the cultural differences that we have between our generations. The, quote, generation gap gives us a different lens, a different way in which we see the world. Some of our older patients are a lot more formal. They expect you to start with sir or ma'am, or say their name as Mr. Anderson or Mrs. Anderson instead of saying, hey, Joe. So formality is somewhat expected in these cases.
Hi, sir.
Who are you?
My name's Jim. I'm a paramedic.
Oh,
What's going on today?
I don't know.
It's also the case that we sometimes see geriatric patients as people who are somehow slower, hard of hearing. They all have dementia. And sometimes we think of them as immobile or sedentary. It's really important not to get stuck in some of those ageisms kind of stereotypes.
For one thing, some of us get crotchety in our old age. Some of us have memory problems. So some of us have cognitive problems. All of us basically are very cognizant of the fact that we're on the downgrade. We have health problems, but we're worried about that. So the word compassion, which you talk about, is important. And it's important that you have to sort of go with care and slowly to make sure that your patient fully understands what you're trying to do and why, because it takes a sales job on your part to do that.
When you're assessing an older person, it can be challenging because of serious differences in the way that they communicate. For example, in our generation, or even in younger generations, we might see people who are much more comfortable exposing their bodies. Older patients may be more private. They want more modesty. So when you do an assessment, be sure to cover them up with a blanket or at least acknowledge the fact that you're going to be a little bit immodest. Sometimes that's absolutely necessary because how else are you going to listen to lung sounds? You've got to get the stethoscope right onto the chest. So you just do it a little more gently, a little more respectfully, and you explain everything you're going to do just like you would with any kind of patient. Sometimes older patients have different social networks than we're used to. They've lost many of their friends, sometimes to illness or death, or they've been separated by distance, sometimes just by geographic location, and they have a fixed income. So they're going to have a little bit of a different idea about what it costs to go to the hospital or to pay for an ambulance bill. Often, older patients have to live in senior living centers or assisted living or even a nursing home. That immediately places them in a category where they have to, by geographic location, be segregated from their normal social networks. That segregation can be an incredible loss of freedom. And sometimes you're the only contact they have with the outside world. It's important to realize that sometimes they will not be happy with their own living quarters.
When we leave our apartments, we worry about such things as our money, our jewelry, our personal effects, whether the door is locked, if we have a pet, what's going to happen to the pet, and that sort of thing. There needs to be a certain amount of assurance given by the EMS team for the folks or the person who's going to be involved in being taken to the hospital, that not to worry, it'll be taken care of, and we'll have all of the things that you need to go along with you.
Part of the differences that happen with older patients is that our bodies begin to adapt and in some cases break down over time, and they're less able to absorb the impact or the insult of a disease or an injury. One of my biggest learning lessons that I would like you not to repeat was when we were wheeling a patient out. My paramedic student was actually at the feet. I was pushing the stretcher from the head. I couldn't see my student, and I couldn't see the patient's arms on either side of the stretcher. And as we went through the door jamb of the nursing home, this patient's elbow was just leaning slightly out. And not only did we hit their elbow, but we ripped a big old avulsion onto their arm. We felt terrible. This was one of the worst cases we could ever have seen of an avulsion, and we had caused it. So really be careful, be gentle, really take your time, make sure their elbows are inside the stretcher, cover them up with a blanket so that they stay warm, but they're also insulated from a little bit of the hustle and bustle and jostle of having to move them from one place to another. So let's talk a little bit about some of those changes, those physiological changes that you need to be alert to so that when you do an assessment, you're not surprised by how different a geriatric patient might be responding or might present in a physical exam. On physical exam, you may see a very loose skin. So in fact, you won't be able to check for skin turgor if you're checking to see if they're hydrated. Normally, when you pinch the skin, it comes right back down. There's no tenting. But in fact, if you pinch the skin and it stays tented, then you know that somebody might be dehydrated. Older patients are very prone to dehydration. And at the same time, their skin is very floppy. And so that skin test may not be very useful. So look for places where the skin is tight across their face or in other parts of their body where you could do that test. Changes to the circulatory system can really wreak havoc on our body as we get older. One of the biggest changes is arteriosclerosis, the hardening of the artery, or atherosclerosis, which is the buildup of plaque inside the artery. Arteriosclerosis doesn't allow our arteries to contract or expand. When the arteries are contracted, then we get an increase in systolic blood pressure. That's also true for atherosclerosis when you have a buildup of plaque, which makes you more susceptible to things like heart attacks and emboli, which cause blockage and cause ischemia.
The heart is perfused by the coronary arteries. As plaque builds up in the artery wall, a condition known as atherosclerosis, the coronary vessels become smaller in diameter. As blood flow is impeded due to the smaller size of the vessel, patients may experience chest pain and other signs of coronary artery disease.
Just the same as our arteries become hardened, so do the mechanisms by which we do venous return, and our veins can also be affected. So what you'll see is the formation of clots like a deep vein thrombosis. In that case, a clot is formed in the back of your leg, sometimes behind your knee, down into your calf. You should see some calf pain, particularly on flexion of the foot. In that case, we want to be very careful because those clots loosen up and can cause a pulmonary embolism or a stroke. We also see that the heart is less capable of speeding up or slowing down, and we see that especially when older patients are on a variety of medications that affect the heart. This is true of any patient, but particularly true of geriatric patients, where we see polypharmacy, many prescribed medications all interacting with each other, sometimes by medical specialists who are not in communication. So you can see a patient being prescribed a beta blocker, a drug that inhibits the beta effects on the heart, which has to do with the strength of the contraction. While at the same time, they might have COPD, in which case they need the beta stimulant in order to open their lungs up so they can breathe better. It's also true that it's going to be harder for you to find pulses, sometimes just because of floppy skin, sometimes because of the hardening or the contraction of those blood vessels to actually feel for those pulses. That's something you can work on in a skills lab to make sure that you can feel for all of the different pulse points. Every time you check a pulse, you'll gain even more skill, more ability, so that when it's harder to find that blood pressure or that pulse point, you'll be better at it.